Hey guys, Robo here. This is a presentation on the workup and acute management of cirrhosis and its many complications. I'll be going over some broad categories of things to look out for and how to deal with them on the inpatient side from the internist's perspective. The purpose of this is to have a guide mainly tailored to junior residents and interns. Note that the guideline recommendations are the most current as of July of 2023. Let's get started. My first slide here has all the major workup and documentation required for cirrhosis management in the inpatient setting. I'll be going over each category here. First up, it's important to document the etiology of the patient's cirrhosis, if known. This may impact treatment options available both for the etiology and the future management of the cirrhosis. One classic example is that if the patient has cirrhosis due to right-sided heart failure, the patient will likely not be a candidate for TIPS. You also want to document the date of diagnosis, if known, whether the cirrhosis is compensated or decompensated, which is defined by the presence of cirrhosis-related complications, and the MELD sodium, and Child-Pugh score. Lastly, it's important to document the following findings, if present, and what diagnostic tests and treatments are currently administered for these complications. Starting off with ascites, you want to start off with a diagnostic paracentesis. From this, you want to send serum and ascites albumin with which you'll determine the SAG, the ascites total protein, the ascites cell count with differential, and culture of the acidic fluid. If the PMNs from the cell count is greater than 250, you want to start ceftriaxone 2 grams Q24 for 5 to 7 days to treat the SBP. If the SAG is less than 1.1, you want to consider other causes of ascites in your differential, such as malignancy and tuberculosis, for which you'll need a CT of the abdomen and pelvis and an A of B culture to evaluate the contents of the peritoneum. If the SAG is greater than 1.1, you would then look at the total protein in the ascites. If the ascites total protein is less than 2.5, the etiology is likely cirrhosis, but if it is greater than 2.5, the etiology is likely cardiac or obstructive, and you would then need an echo or hepatic venous Doppler to further evaluate. It's also important to grade the ascites, since this determines management. Grade 1 or subclinical ascites, which was likely picked up incidentally on imaging, should improve with sodium restriction of less than 2 grams per day. Grade 2 ascites presents with moderate abdominal distension and is usually treated with Lasix and spironolactone in addition to sodium restriction. Grade 3 or refractory ascites is usually refractory to diuretics and requires large volume paracentesis. Note that for every liter of ascites removed, you must replace it with 6 to 8 grams of albumin per liter removed. This is to prevent PBCD. At this stage of ascites, the patient would require hepatology referral for possible TIPS evaluation. The next complication to cover is GI bleeding, which is often variceal but can be any portal hypertension-related bleeding. This requires prompt identification and management, including blood transfusion to a goal hemoglobin of 7, a BID PPI for peptic ulcer prophylaxis, ceftriaxone 1 grams Q24 for SBP prophylaxis for 7 days, octreotide bolus and drip for 2 to 5 days, and a GI or hepatology consult for EGD and variceal tamponade/ablation if the patient is hemodynamically stable. In terms of prevention of recurrent bleeding, you want to add one of the following beta blockers after discontinuing the octreotide drip, but not during the hemorrhagic phase, since the patient may go into hemorrhagic shock and a beta blocker will further drop the patient's blood pressure. Next, we have hepatic encephalopathy, or HE. It's important to grade the HE as this will affect treatment. Note that the presence of asterixis categorizes HE as grade 2, and grade 3 and above is considered severe HE. It's also important to consider the etiology of the HE, as this may be reversible and preventable, and the reduction of these causes may prevent future HE episodes. The first-line therapy for HE is either lactulose or Marilax, titrated to 3 to 4 bowel movements per day. If a patient has grade 3 encephalopathy and above, meaning the patient is confused, lethargic, somnolent, or comatose, administer a lactulose enema. If the patient is comatose, evaluate for airway protection and consider intubation. Second-line therapy is rifaximin, which is usually started at the time of discharge or after acute episodes of HE, since most studies reported benefit at 3 to 6 months. Next, we have hepatorenal syndrome or HRS. The first step in this process is to make sure that the patient actually has HRS versus prerenal AKI from decreased intravascular volume, or ATN, from hyperperfusion. The first step is to provide an albumin challenge of 1 gram per kilogram per day for 2 days. This is effectively the same thing as giving a fluid bolus that doesn't leave your vasculature. If a patient's creatinine recovers in 2 days, this was likely a pre-renal AKI and you have effectively ruled out HRS. If the patient's creatinine does not recover, then you must send a UA, urine microscopy, and renal ultrasound. If you do not see evidence of ATN, i.e. muddy brown casts on microscopy, this is likely HRS. Note that type 2 HRS, aka the chronic version of this disease, has little diagnostic value since it has the same criteria and management decisions as CKD. Thus, only type 1 HRS, also called AKI HRS, is of diagnostic value here. The first-line therapy for HRS is terlipressin, but this drug is currently not approved in the US or in Canada. As such, we move to the second-line treatment, which is octreotide and midodrine. Patients should also be evaluated by hepatology for simultaneous liver and kidney transplant. Next, we have hepatocellular carcinoma, or HCC. HCC is one of the few malignancies, along with multiple myeloma, if certain kappa lambda ratios are met, that does not actually require a biopsy to diagnose. The mainstay of evaluation is imaging via MRI or CT with contrast. Note that while the AASLD recommends either one, the MRI has higher sensitivity for similar specificity, so I usually opt for the MRI. From this imaging, the radiologist will calculate a LIRAD score, which can be used to diagnose individuals with HCC without biopsy if they are considered a high-risk population, such as individuals with cirrhosis. You also want to get an AFP, or have one from the past 6 months to be able to trend it and correlate it with imaging findings. If LIRAD findings are consistent with HCC, i.e. LR5, consider chest CT to rule out metastasis, as well as CT abdomen pelvis if the pelvis was not imaged in the MRI or CT that was used for the LIRAD's evaluation. Lastly, we have hyponatremia. If the patient has hyponatremia between 126 and 135 milliAQs and is not symptomatic, treat with mild fluid restrictions, anywhere from 1.5 to 2 liters of fluid. If the patient has a sodium between 120 and 125, fluid restriction should be decreased to 1 liter per day and diuretics should be discontinued. If the sodium is less than 120 milliAQs, fluid restrict less than 1 liter per day, stop diuretics, and consider albumin infusion. Consider discussing with hepatology about tolvaptan use. It is important to be judicious when using tolvaptan since it has a black box warning for liver injury, which is severely detrimental in patients with cirrhosis at baseline. And as always, remember to not exceed 8 milliAQs of sodium rise per day to avoid osmotic demyelination syndrome. That's it for me. Let me know if I made any mistakes in the comment section below or if you have any questions. See you guys soon.